Hello and welcome back to the PMHNP Podcast. This is Dr. John Rossi with Clarity Education Systems, also known as PMHNPtesting.com. So today we are going to dive into ADHD, or Attention Deficit Hyperactivity Disorder. So you can catch this on Podbean or on Apple Podcast, YouTube, also on the student portal for those that are enrolled in our PMHNP review programs. So DSM-5 criteria for ADHD. We have to know this criteria because it's going to be essential for the exam and also in your clinical practice as you go on and you go out and actually do this in the real world. So DSM-5 outlines specific diagnostic criteria for ADHD. Remember, this is a neurodevelopmental disorder that's characterized by persistent patterns of inattention and or hyperactivity-impulsivity. And this is inconsistent with an individual's developmental level, and it also impairs function on a daily basis. So these symptoms must be present in two or more settings, like at the home, in school, or at work, and it must cause significant impairment in daily life. So let's break down step by step, and we're going to focus on what you need to know for the certification review. So first, DSM-5 identifies two core symptom domains. Remember, the first is going to be inattention, and the second is going to be hyperactivity-impulsivity. A diagnosis of ADHD requires meeting criteria for one or both, depending on the presentation. So here's how it works. Let's first look at inattention. So for children 17 and under, at least 6 of the following symptoms must be present for at least 6 months to a degree that it's inappropriate for their developmental level. For individuals over 17 or 18 and older, 5 symptoms are required, and all of these are going to include often fails to give close attention to details or makes careless mistakes in schoolwork, work, or other activities, often has difficulty sustaining attention in tasks or play, often does not seem to listen when spoken to directly, often does not follow through on instructions and fails to finish tasks, often has difficulty organizing tasks or activities, often avoids or is reluctant to engage in tasks requiring sustained mental effort, often loses things necessary for the task like school materials or their keys or wallet, is often easily distracted by external stimuli, and is often forgetful in daily activities. So picture a student who misplaces their homework, zones out during lectures, or struggles to prioritize assignments. These are key classic signs of inattention. Second, we have the hyperactivity and impulsivity. Again, 6 symptoms for kids, 5 or more for those older, and it must persist for at least 6 months. So this is going to include often fidgeting or taps their hands and feet, or they squirm a lot in their seat. Often leaves their seat in situations where remaining seated is really expected. Often runs about or climbs in inappropriate situations. So in adolescents or adults, this may manifest as, restlessness, right? Often unable to play or engage in activities quietly. Is often on the go, acting as if they are driven by a motor, and they'll often say those words. Often talks excessively, blurts out answers before the question is completed, has difficulty waiting their turn, and finally interrupts or intrudes on others, like butting into the conversation when they're playing a game, or just can't wait to say what needs to be said, and so they scream it out. So think of a child who can't stay seated in class, or an adult who impulsively interrupts colleagues at work. These behaviors disrupt functioning across multiple settings. Now, ADHD is classified into 3 presentations based on which symptoms are predominant. So first is predominantly inattentive presentation, and that's going to meet criteria for the inattention, but not hyperactive-impulsive. Then there's predominantly hyperactive impulsive presentation, where we meet the criteria for hyperactivity and impulsivity, but obviously not inattention. And then finally, your third presentation is combined, and that meets criteria for both inattention and hyperactivity impulsivity. Now, these presentations can shift over time. So as PMHNPs, you'll need to reassess patients periodically. And for the exam, remember, the combined presentation is the most common in children, while adults often present with predominantly inattentive symptoms. Now, beyond symptoms, the DSM-5 has additional requirements here. Age of onset is very important. Several symptoms must be present before the age of 12. So this is critical. ADHD is a neurodevelopmental disorder, so symptoms don't suddenly appear in adulthood without childhood history. It has to occur in multiple settings. So symptoms must occur in at least 2 or more settings, like home and school, in order to rule out situational factors. So they can't just be bad at math and everything else is totally fine, right? There needs to be problems at school and at home, so on and so forth. The third requirement here is going to be functional impairment. So symptoms must interfere with social, academic, or occupational functioning. And then finally, exclusion for other disorders. So symptoms shouldn't be better explained by another mental health condition like anxiety, a mood disorder, or substance use. And we're really using that like multiple setting and, ongoing daily functional impairment to help differentiate between those other disorders and ADHD. So for the exam, expect questions that test your ability to differentiate ADHD from the lookalikes. Remember, anxiety, right? Learning disorders. And all of this is based on these criteria. You'll also need to know how to apply the symptom thresholds for the different age groups. So that's the DSM-5 criteria for ADHD in a nutshell. All right, keep these in your mental toolkit. 6 symptoms for kids, 5 for adults, 2 domains, 3 presentations, and those extra requirements like age of onset and the amount of impairment. So next, we're going to look at the differential diagnoses. We want to sharpen the clinical reasoning here, okay? So as we move on, this is where you have to really start to solidify the different types of disorders and your differentials so that you can best diagnose your patient. All right, so navigating the differential disorders and the diagnoses for ADHD, we're looking at these misdiagnoses that often happen in the clinical setting, and that's going to lead to ineffective treatment. So let's sharpen our clinical reasoning and explore those conditions that can mimic ADHD. Okay, so ADHD core symptoms, remember, it's inattention, hyperactivity, impulsivity, aren't unique to ADHD. Many psychiatric, medical, and environmental conditions can present in similar ways. As future and current PMHNPs, you're going to need to tease these apart. For the certification exam, expect case-based questions that challenge you to rule out other disorders based on history, presentation, and the DSM-5 criteria. So let's go ahead and walk through the key differential diagnoses for ADHD, and then we're going to focus on what sets them apart. All right, first up, we have anxiety disorders. So anxiety can look a lot like ADHD, especially the inattentive presentation. A child or an adult with generalized anxiety disorder, or GAD, or some type of social anxiety, they may appear distracted, forgetful, fidgety, and this is due to excessive worry and hypervigilance. Unlike ADHD, anxiety-driven inattention is often tied to specific triggers like social situations or performance pressure. So key differentiator here, ADHD symptoms are pervasive across settings, while anxiety symptoms may fluctuate based on the stressor. We want to ask about worry, fear, or physical symptoms like a racing heart in order to rule out anxiety in general. All right, number 2 are just in general mood disorders. So bipolar disorder and major depressive disorder can mimic ADHD. In bipolar disorder, especially in children, the irritability, impulsivity, and high energy during manic or hypomanic episodes, it really does look like ADHD's hyperactivity-impulsivity. Now, depression, on the other hand, this can cause poor concentration, low motivation, and mimicking inattention. So the key here is timing. ADHD symptoms are chronic and present before the age of 12, while mood disorders often have episodic symptoms or this kind of later onset in later adolescence. So look for mood-specific signs like euphoria or suicidal ideation to guide the diagnosis. All right, number 3 is learning disorders. So specific learning disorders like dyslexia or dyscalculia, these can cause academic struggles that look a lot like ADHD inattention. A student who can't focus on reading or math may seem distractible, But the issue is task specific. It's not pervasive. Unlike ADHD, learning disorders don't typically involve hyperactivity or impulsivity. So use academic history and psychoeducational testing to differentiate. ADHD affects multiple domains, not just one subject. Number 4 is oppositional defiant disorder, or ODD. Now, ODD is very common in children, and it involves defiance and argumentativeness, and this can overlap the ADHD impulsivity and emotional dysregulation. But ODD behaviors are typically directed at authority figures and stem from emotional reactivity, not neurodevelopmental deficits. So ADHD kids may act impulsively across contexts, while ODD behaviors are more situational. So check for patterns of hostility or vindictiveness to lean towards ODD. Okay, number 5 is autism spectrum disorder, or ASD. And this can present with social difficulties and deficits, repetitive behaviors, and trouble focusing, which may be mistaken for ADHD. Both conditions can involve impulsivity or inattention. But ASD includes core deficits in social communication and restricted interests. So an example here, an ADHD child may interpret or interrupt due to impulsivity, while an autism child might struggle with conversational reciprocity, or that kind of back and forth conversation. Now, developmental history and social interaction patterns are key to distinguishing between ADHD and autism. All right, number 6 is going to be just medical conditions in general, so don't overlook the physical health, right? Conditions like thyroid disorders, sleep apnea, or lead exposure can cause inattention or hyperactivity. For example, hypothyroidism can lead to sluggishness or poor focus, while sleep apnea causes daytime fatigue that mimics inattention. So seizure disorders like absent seizures, these can look like zoning out. Also, you want to ask about medical history, sleep patterns, and neurological symptoms. So lab tests or referrals may be needed in order to rule out these medical conditions when looking between this and ADHD. All right, number 7 is going to be substance use or medication effects. So in adolescents and in adults, substance use like cannabis, alcohol, or stimulants, these can impair attention. This can cause agitation. It can mimic ADHD. So like medications, let's think about antihistamines or corticosteroids. This can affect focus, and this can affect behavior. So unlike ADHD, these effects are tied to substance use or medication timing, not a lifelong pattern. So a thorough substance and medication history is going to be vital, especially for adult patients. Finally, we're going to talk about environmental factors, so things like trauma, neglect, or chaotic home environments. These can all lead to behaviors that resemble ADHD, especially in children. So chronic stress may cause hypervigilance or difficulty concentrating, but these are often context-specific, and they lack the early onset of ADHD symptoms. So you want to use trauma-informed screening tools and gather a detailed psychosocial history in order to differentiate between environmental factors and ADHD. So for the exam, this is our pro tip for this. You want to focus on onset, context, and co-occurring symptoms. ADHD starts before age 12, is consistent across settings, and is not better explained by another condition. A good history, collateral from the parents, teachers, and partners, is your best tool. Also, you want to watch for comorbidities because ADHD often coexists with anxiety, depression, or learning disorders, and that's going to complicate your picture. All right, so that's really a good rundown of the top differential diagnoses for ADHD. So keep them in mind: anxiety, mood disorders, learning disorders, ODD, autism, medical conditions, and substance use, and the environmental factors. So you want to practice ruling those out with case studies, and that's going to help you really hone in on those exam-style questions. Next, we do need to explore the evidence-based treatments for ADHD, and that's going to help round out our certification prep for the ADHD section. So we'll go ahead and move over into treatment-specific. So remember, This is a part of your scientific foundations whenever we're understanding the science behind ADHD and then the treatment options behind ADHD. So just recall, this is a neurodevelopmental disorder, and it's rooted in complex interactions between genetics, brain structure, and neurochemistry, right? So as PMHNPs, knowing the science helps explain the disorder to the patients, and it justifies your treatment choices. And that's what's going to help you on the exam questions that look at things like pathophysiology and neurobiology. So let's break it down, okay? We're first going to look at neurotransmitters, then we're going to look at brain structures, and then we're going to look at associated abnormalities. We have to focus in on these scientific foundation areas before we can actually roll into the treatments that are available. All right, so first up we have neurotransmitters, and these are chemical messengers. So ADHD is strongly linked to dysregulation of two key neurotransmitters, dopamine and norepinephrine. These chemicals regulate attention, motivation, and impulse control, and in ADHD, their signaling is disrupted. So first of all is dopamine. This neurotransmitter is critical for reward processing, motivation, and sustained attention. In ADHD, there is evidence of reduced dopamine activity in certain brain regions, leading to difficulties focusing on tasks that aren't immediately rewarding. So think of a patient who can play video games for hours but struggles with homework, right? Low dopamine signaling makes mundane tasks feel rewarding. Then there's norepinephrine. So this neurotransmitter modulates arousal, alertness, and effective executive functioning. So things like planning and impulse control. In ADHD, norepinephrine imbalances contribute to distractibility and impulse behaviors. It's why patients might act without thinking or struggle to stay on task. So the catecholamine hypothesis, this ties these two together, suggesting that ADHD results from impaired dopamine and norepinephrine transmission in neural circuits. Medications like methylphenidate and amphetamines, they work by increasing the availability of these neurotransmitters in synapses, and that's improving attention and then improving impulse control. So for the exam, know that dopamine and norepinephrine are the stars of the ADHD neurochemical show. Number 2 is brain structures, and this is the neural architecture. So ADHD is associated with differences in several brain regions that are involved in attention, executive functioning, and motor control. So neuroimaging studies like MRIs and functional MRIs, they show structural and functional abnormalities in some key areas. So first up is the prefrontal cortex, or the PFC, especially in the dorsolateral prefrontal cortex. This is crucial for executive functionings like planning, working memory, and impulse control. So in ADHD, the PFC is often underactive or smaller in volume, leading to difficulties organizing tasks or inhibiting impulsive actions. This is why a patient might blurt out answers or struggle to prioritize. Next is the anterior cingulate cortex, or the ACC. The ACC helps with error detection, with emotional regulation, and attention allocation. In ADHD, reduced ACC activity contributes to problems shifting focus or regulating emotions. And that explains why patients might get, stuck on a task or overreact to frustrations. Third is going to be the basal ganglia. So this is a group of structures that includes the striatum. This regulates motor activity and reward processing. In ADHD, the basal ganglia show reduced volume and altered dopamine signaling, contributing to hyperactivity and impulsivity. So think of a child who fidgets constantly. This could be tied back to the basal ganglia dysfunction. Then we have the cerebellum. So traditionally, this is linked to motor coordination. The cerebellum also plays a role in cognitive timing and attention. In ADHD, cerebellar abnormalities, particularly in the vermis, are associated with difficulties in timing tasks or sustaining attention. And this can really manifest as poor time management. Then finally, we have the corpus callosum. This is the structure that connects brain's hemispheres, right? So this is going to facilitate communication between the two hemispheres. Now, in ADHD, a smaller or less efficient corpus callosum may impair integration of cognitive and emotional processes, and that's what's going to contribute to disorganized behavior. So for the exam, I want you to remember the frontostriatal cerebellar circuit. This is a key player in ADHD. So dysfunction in the frontostriatal cerebellar circuit, that's a network disruption, and the brain's ability to regulate attention, behavior, and emotions is inhibited or messed up for the easiest terms. All right, and the number 3 here is abnormalities and contributing factors. So beyond neurotransmitters and the structures, ADHD is also associated with several abnormalities and risk factors that shape the neurobiology. So first is genetic factors. ADHD has a high heritability rate, estimated at around 70 to 80%. So genes involved in dopamine regulation are the DRD2, that's a dopamine D2 receptor, and the DAT1, or the dopamine transporter. These genes are usually implicated. So these genetic variations affect how dopamine is processed, contributing to ADHD symptoms in general. So for the exam, you need to know that ADHD often runs in families, and a strong family history is a red flag. Second is structural and functional abnormalities. So remember, we talked about neuroimaging before in the previous section, and it shows that individuals with ADHD often have delayed cortical maturation, particularly in the prefrontal cortex, with weak cortical thickness occurring later than their peers do. So this delay aligns with symptoms improving in some individuals as they age. So functional studies also reveal hypoactivation in attention-related networks and hyperactivation in default mode networks. And so that explains why patients struggle to stay focused. Number 3 is white matter differences. So diffusion centers imaging, this is going to help reveal some altered white matter tracks. Okay, again, that's diffusion tensor imaging. That's going to reveal the altered white matter tracks. Things like the superior longitudinal fasciculus, which is going to connect the frontal and the parietal regions. So these differences impair efficiency, they impair communication between the brain areas, and that's what's contributing to the executive dysfunction of the brain. All right, next is going to be the environmental factors. So, we said genetics plays a big role, right? Environmental factors like prenatal exposure to toxins, things like alcohol or tobacco, things like low birth weight, or early psychosocial adversity can increase ADHD risk as well. So these factors may disrupt neurodevelopment and amplify genetic predispositions for the patient. Then finally, we have neuroinflammation and oxidative stress. So emerging research suggests that low-grade inflammation or oxidative stress in the brain may contribute to ADHD by affecting neuronal signaling. So this is still an evolving area. It's fascinating, really, but it does highlight the complexity of the disorder. So let's tie together all of these topics for the certification prep. ADHD stems from dysregulation of dopamine and norepinephrine with key brain regions like the prefrontal cortex, the basal ganglia, and the cerebellum, showing structural and functional differences. Genetic factors, delayed cortical maturation, and environmental influences further shape the disorder. So for the exam, expect questions that link these mechanisms to symptoms or treatments, like why stimulants target dopamine or how prefrontal deficits cause impulsivity. So that's the scientific foundation of ADHD. We want to keep these concepts. Remember, catecholamines, the frontostriatal cerebellar circuits, and genetic environmental interplay. Now we can dive into treatment strategies to bring this all to life for the practice and how we can help our patients that are, struggling early in childhood or later in adulthood with ADHD symptoms. So screening for ADHD is the first step in diagnosis. And as future PMHNPs or currently practicing providers, you need to know how to do it efficiently and effectively. ADHD symptoms can overlap with other conditions like we talked about, so a structured, evidence-based approach is going to be essential. Plus, Since ADHD manifests across settings like home and school, input from parents and teachers is invaluable for a complete picture. So let's break this down into 3 parts. 1 is going to be the importance of screening. 2 is going to be the best tools. And then finally, 3, the critical role of parents and teachers. So remember, this is the first part of our treatment plan. So screening for ADHD is about identifying individuals who need a full diagnostic evaluation while ruling out other causes of inattention, hyperactivity, and impulsivity. Early and accurate screening can prevent misdiagnosis, it can reduce functional impairment, and it can improve overall outcomes. So for children, this might mean better academic performance and social skills, while for adults, this could improve work productivity and their relationships. Now, the DSM-5 requires symptoms to be present in 2 or more settings and cause significant impairment, which makes screening a collaborative effort. Without proper screening, you miss ADHD altogether, or you mistake it for anxiety, a learning disorder, or those behavioral issues. So for your certification exam, expect questions that test your ability to select appropriate screening tools and interpret findings from multiple sources. Screening isn't just about checking boxes. It's about setting the stage for holistic care. So there's no single test for ADHD, so screening relies on standardized, validated tools that gather information about symptoms, the severity, and impairment. Now, these tools are typically rating scales or questionnaires completed by patients, parents, teachers, or other caregivers. So here are some of the best tools that you need to know for the exam and in practice. First and foremost, we have the Vanderbilt ADHD Diagnostic Rating Scale. So this is the go-to tool for children ages 6 to 12. It includes parent and teacher versions, assessing DSM-5 criteria for inattention, hyperactivity, impulsivity, and common comorbidities like ODD or anxiety. Now, the Vanderbilt is free, it's easy to score, and it is widely used in primary care and mental health settings. It's a favorite for exam questions because it covers multiple domains and settings. The next one is the Conners Rating Scale, also known as the Conners 4. So this one was recently updated. That's why it's called the Conners 4. It's comprehensive for children aged 6 to 18 with parent, teacher, and self-report versions. So this one is going to evaluate ADHD symptoms, executive functioning, and emotional ability. It includes a short form for quick screening. Now, its strength is its sensitivity to symptoms, severity, and impairment, making this one an ideal for tracking treatment response. So you want to know this one for its versatility and its psychometric rigor. The next is the ADHD Rating Scale 5. So this scale aligns directly with DSM-5 criteria and is used for children and adolescents, typically age 5 to 17. So it has a parent and teacher version. It focuses on frequency and severity of 18 DSM-5 symptoms. It's quick, reliable, and great for initial screening and monitoring the progress of the patient. So for the exam, note its specificity to ADHD symptoms. Next, we have the ADHD Adult Self-Report Scale, or the ASRS. This is version 1.1. This is for adults, right? The ASRS is the gold standard for adult assessment. This was developed by the World Health Organization. It's a 6-item screening tool. Part A, first it identifies adults needing further evaluation with an optional 18-item checklist. Part B, for the symptom details. This one is quick, it's free, and it's sensitive to adult-specific presentations like disorganization and restfulness. So expect this one on your exam for the adult ADHD cases. Another one I want you to remember is the Winder-Utah Rating Scale. We will also use this for adults. It asks specifically about childhood symptoms to an adult patient. Last, we have the Behavior Assessment System for children. So while broader than ADHD-specific tools, this is the BASC3, or the Behavior Assessment System for Children. This one assesses for behavior, emotions, and adaptive skills in children and adolescents. So parent, teacher, and self-report forms make it a useful tool for identifying ADHD alongside other comorbidities like anxiety and depression. So it's less specific to ADHD, but it is a really great tool for differential diagnosing. So for the exam, you want to focus on the Vanderbilt, the Conners for kids, and the ASRS for adults. So these tools are evidence-based, and they align with the DSM-5 and are a practical use in a clinical setting. So always combine them with a thorough clinical interview and a very thorough health and mental health history to confirm findings, as no tool, remember this, no tool is diagnostic on its own. That's why you are there. All right, and then number 3, we talked about the critical role of parents and teachers. So parents and teachers are your eyes and ears in the diagnostic process. Since ADHD symptoms must present in multiple settings, their observations are essential for meeting the DSM-5 criteria and then ruling out situational factors. So here's why it matters and how to leverage their input. First, let's talk about the parents. So parents provide insight into a child's behavior at home, right? Sometimes they also provide the homeschool or the teacher aspect as well. They provide home. They show daily routines at home and in social situations. They report on early developmental history, symptom onset. Remember, that's crucial for DSM-5, right? Because symptoms have to appear before the age of 12. And we also see the family dynamics here that might influence behavior. So for adults, partners or family members can often give you some similar collateral input. Parents also help identify functional impairment, like struggles with homework or chores, and can flag comorbidities like anxiety or sleep issues. So engage parents with tools like the Vanderbilt or the Conners and ask open-ended questions like, how does your child's behavior compare to their peers, so on and so forth. Next is teachers. So teachers observe children in structured settings where ADHD symptoms like inattention or impulsivity are often most apparent. They can compare a child's behavior to classmates, providing a developmental benchmark. Now, for example, a teacher might note a student can't stay seated during lessons or frequently interrupts, which is going to align with the hyperactivity-impulsivity. Teacher versions of the Vanderbilt, the Conners, or the ADHD RS5, these are going to be critical for capturing school-based symptoms. For the exam, know that discrepancies between parent and teacher reports do not rule out ADHD. Different settings may highlight different symptoms. So why does collaboration matter? Parents and teachers provide ecological validity, ensuring symptoms aren't context-specific. For example, due to some type of stressful home environment or a challenging classroom. Their input helps differentiate ADHD from lookalikes like learning disorders or trauma. For example, a teacher might note academic struggles specific to reading, pointing to a learning disorder, while a parent might describe pervasive inattention, supporting ADHD. Involving both also builds trust and ensures interventions like behavioral strategies or a 504 plan are feasible across the settings. So for the exam, expect scenarios where you interpret parent and teacher reports to confirm ADHD or identify red flags for differential diagnoses. So here's a pro tip. If a parent and teacher ratings conflict, dig deeper into a clinical interview for additional collateral sources like coaches or even babysitters. So let's go ahead and wrap this part up. Screening for ADHD is collaborative. It's evidence-based process that hinges on the validity of tools like the Vanderbilt, the Conners, the ASRS, the Winder, Utah. Parents and teachers are your partners in this process. They're going to provide that critical data on symptoms and impairments across settings. So for the exam, know the tool's age ranges, who completes them, and how to integrate multi-source data. So this approach ensures accurate diagnosing and sets the stage for effective treatment. All right, and now we're going to roll into that section. Diagnosing attention deficit hyperactivity disorder in adults who were never diagnosed as children can be a difficult and challenging situation. You have to make sure that you are assessing a complete, family health history, psychosocial history, and current work environment history. Have they been written up? Have they been fired from multiple jobs? Do they keep breaking up with girlfriends or boyfriends? Taking all of these struggles into account while you're also paying attention to their childhood. Sorry, I just wanted to jump back a little bit because we didn't talk about older adults too much. It's very rare. It's last research that I read was less than 4% of adults will actually present with ADHD that have never been diagnosed previously. Okay, so it does happen, but we have to be very careful because it's probably linked to some other problem if they were never diagnosed or had significant issues as a child. All right, so stigma is also a big part for adults. Historically, ADHD was viewed as a childhood disorder, right? And it is. Because it's a neurodevelopmental disorder. And early research focused on boys alone. So that also played a part in gender problems. And that led to an underdiagnosis situation for children and adults, especially women and minorities. So adults may not look for or seek for help because of stigma that they had when they were younger, their parents, had the stigma, or just general lack of awareness that ADHD persists into adulthood if they were never diagnosed as a child, and that's going to delay the diagnosis until significant impairment occurs. All right. So just, little side note here for the exam, know that challenges in adulthood require a thorough history and collateral information to meet the DSM-5 criteria, especially the age of onset, right? Because even though they're coming at you as an adult, you still have to identify those early childhood before the age of 12 symptoms. Misdiagnosing is high in the adult population, so you have to take a systematic approach in order to diagnose properly. Okay, so let's move on to the pharmacological treatments of ADHD. We'll talk about some of the non-pharm, but let's first dive into pharmacological treatments. We're going to cover FDA recommendations first, the first, second, and third line choices, both stimulant and non-stimulant medications, along with the ages, the mechanisms of action, adverse reactions, and side effects. This is a very high-yield section for your exam, so do not skip over this. Pharmacological treatment is the cornerstone of ADHD treatment. It's often combined with behavioral interventions for optimal outcomes. So as PMHNPs, you'll need to know which medications are FDA approved and then how to prioritize them and how they work, and while balancing benefits versus the risks when determining which medications to take. So for the certification exam, you will expect questions on medication selection, age-specific indications, and side effect management. So let's break down systematically, first looking at the FDA recommendations, the treatment hierarchy, remember those first and second and third line options, and then key details on stimulants and non-stimulants. All right, FDA recommendations for ADHD medications. The FDA has approved a range of medications for ADHD, primarily stimulants and non-stimulants based on robust evidence of efficacy and safety. These medications target neurobiological underpinnings of ADHD, particularly that dysregulation of dopamine and norepinephrine in the prefrontal cortex and basal ganglia. So the FDA approves medications for specific age groups, and treatment decisions should align with these indications. Remember, patient age, comorbidities, and preferences. So general principles are going to include, first, stimulants. These are the most effective first-line treatments for ADHD, with a response rate of something in the realm of 70 to 80% in children and adults. Non-stimulants are typically second or third line options. They're used when stimulants are ineffective, they're contraindicated, or they're just not tolerated by the patient. Age-specific approvals, most medications are approved for children as young as 6, with some extending even into age 3, for example, certain amphetamines. Or adults can also take these, right? So preschoolers under 6 require caution, specialist-driven management. And then there's the monitoring. So regular follow-up is going to be essential to assess efficacy, side effects, and growth in children, with baseline vitals and cardiac history to screen for risks. So for the exam, know that FDA prioritizes stimulants for their efficacy, but approves non-stimulants for flexibility, especially in patients with substance use disorders or cardiac conditions. So the treatment hierarchy, the first, second, and third lines. Pharmacological options are going to be categorized by line of treatment based on the efficacy, the evidence, and clinical guidelines. And this is all brought to you by the American Academy of Pediatrics, the AACAP. So let's discuss the hierarchy in detail. First line stimulants. Stimulants are considered the gold standard to their rapid onset, high efficacy, and extensive evidence base. They're divided into methylphenidate-based and amphetamine-based formulations. And these are available in short-acting, intermediate-acting, and long-acting forms. Let's talk about methylphenidate-based first. So we have Ritalin, Concerta. These are ages 6 and older, children, adolescents, and adults. Now, for most formulations, some are approved for 3 to 5 in specialist settings, but we're not going to worry about that for the exam. Mechanism of action, this is going to, the methylphenidate-based are going to block the reuptake of dopamine and norepinephrine, and that's going to increase their availability in the prefrontal cortex and striatum to enhance attention and reduce impulsivity. So some of the examples here are going to be short-acting, like Ritalin or Methylin, 4 to 6 hours and 6+ years of age. Long-acting is going to be something like Concerta, osmotic release, 10 to 12 hours, ages 6 and older. Daytrana, this is a transdermal patch, 9 to 12 hours long for 6+ years of age and older. Adverse reactions or side effects. So common are going to include insomnia, decreased appetite, weight loss, headache, irritability, and increased heart rate, blood pressure. Rare but serious are your cardiac events like arrhythmias in predisposed patients, psychosis, and priapisms. So monitor growth in children, as long-term use can slow growth velocity. So you want to have a good relationship with their pediatric provider. Now, quick note here, Concerta's extended release minimizes abuse potential, and Daytrana's patch is useful for patients who can't swallow pills. We want to titrate slowly in order to balance efficacy and side effects. All right, now let's dive into amphetamine-based. This is going to be your Adderall, Vyvanse, Dexedrine. So approved for 3 and older for some, like Dexedrine, 6 and older for most, Adderall, Vyvanse, and they're all approved for adults. Mechanism of action, we have increase in release and blocks reuptake of dopamine and norepinephrine, and that's going to boost attention and executive function. Now, some examples are short-acting Adderall IR or Dexedrine, 4 to 6 hours, 3+ years for Dexedrine, 6+ for Adderall. Long-acting are going to be Vyvanse, so 10 to 14 hours long, 6+ years and older. Adderall extended release, 8 to 12 hours for 6+ years and older. Now, adverse reactions and side effects. These are going to be similar to methylphenidate. So things like insomnia, appetite suppression, weight loss, anxiety, irritability, and cardiovascular effects. Things like tachycardia. So rare risks are going to include sudden cardiac death in patients with pre-existing heart conditions and potential for abuse or dependence due to the euphoric effects. So Vyvanse's pro-drug design reduces abuse risk. Note here, Vyvanse is long-acting and less abusable, making it a top choice for adolescents and adults. We want to screen for cardiac history and substance use before prescribing. So why are these first line? Remember, stimulants have the highest effect size, 0.8 to 1, for reducing ADHD symptoms across ages. They're preferred unless contraindicated. Those contraindications are going to be cardiac issues, substance use, or severe side effects. For the exam, know that methylphenidate and amphetamines are equally effective with choice guided by patient response and tolerability. Okay, let's dive into second line. These are going to be your non-stimulants, things like atomoxetine, guanfacine, or clonidine. Non-stimulants are used when stimulants fail, are not well tolerated, or they are contraindicated. For example, in patients with substance use disorders or they have tics. They're less effective, but they do have lower abuse potential and fewer cardiovascular risks. So first is going to be atomoxetine or Strattera. This is approved for ages 6 and older, children, adolescents, and adults. The mechanism of action here is selective norepinephrine reuptake inhibitor, or an NRI. increasing norepinephrine and indirectly dopamine in the prefrontal cortex, and that's going to improve attention and impulse control. Unlike stimulants, it has no effect on the striatal dopamine, reducing abuse potential. Adverse reactions and side effects for atomoxetine, common are going to be your nausea, dry mouth, fatigue, decreased appetite, and sexual dysfunction in adults. Rare but serious are hepatotoxicity, so we do need to monitor liver function. Suicidal ideation, there is a black box warning for youth, right, 24 years of age and younger, and cardiovascular effects, so increased heart rate. It does take about 4 to 6 weeks for the full effect, unlike stimulants that have a rapid onset. So quick note for atomoxetine, this is ideal for patients with anxiety, tics, or substance use history. They do require daily dosing and patients due to the delayed onset. So for the exam, know its non-controlled substance status. Next is guanfacine extended release, also known as Intuitive. This is approved for children 6 to 17, children and adolescents. It is off-label for adults. Mechanism of action, this is an alpha-2-alpha adrenergic agonist, okay? So this enhances prefrontal cortex connectivity to improve attention, impulse control, and emotional regulation. It reduces hyperactivity by modulating norepinephrine. Common side effects, adverse reactions, sedation, fatigue, hypotension, and headache. Rare are going to be bradycardia or rebound hypertension if stopped abruptly. So we do need to taper slowly to avoid withdrawal effects. Note for guanfacine, often used as monotherapy or adjunctive to stimulants for hyperactivity or emotional dysregulation. Non-controlled, making it safe for substance use concerns. And then we do need to monitor blood pressure. Next, we have clonidine extended release. So this is approved for ages 6 to 17, children and adolescent. It is off-label for adults. Mechanism is an alpha-2 adrenergic agonist, similar to guanfacine, reducing hyperactivity and improving attention by modulating norepinephrine signaling. Similar to guanfacine, we can see sedation, hypotension, fatigue, and dry mouth. Our rare are going to be cardiac effects or rebound hypertension, so we do have to taper this drug. The quick note here is it's useful for hyperactivity, for aggression, and for sleep issues in ADHD, often adjunctive with the stimulant, and we do need to monitor vitals regularly. So why are these second line? Non-stimulants have lower effect sizes, 0.5 to 0.7, but are safer for patients with stimulant contraindications. Atomoxetine is preferred for broad symptom coverage. Guanfacine and clonidine target hyperactivity and adjunctive treatment. So for the exam, know their slower onset and non-controlled status. Now, we do need to talk about some third-line treatments. Third-line are labeled, off-label use, are less studied but used when first- and second-line treatments fail. These are going to include things like bupropion, tricyclic antidepressants, and modafinil. All right, so Wellbutrin, approved ages, not approved for ADHD. It's used off-label in adults, 18 and older. The mechanism of action, dopamine and norepinephrine reuptake inhibitor, and that enhances attention and motivation. Also an antidepressant, so it's useful for comorbid depression and ADHD. Some of the common adverse reactions here are going to be insomnia, agitation, dry mouth, and headache. Rare are going to be seizures, so it is contraindicated in seizure disorders or if a patient has an eating disorder, because eating disorders also lower the seizure threshold. And it can also cause suicidal ideation in the adolescent childhood population. So we avoid in eating disorders due to that seizure risk that I just talked about. So a good note here is for adults with ADHD and depression or smoking cessation needs. It's non-controlled but less effective than stimulants. Tricyclic antidepressants. So these are not approved for ADHD. It's off-label in adults or adolescents. Mechanism of action here is it inhibits norepinephrine and serotonin reuptake, improving attention and mood. So it's less specific to ADHD pathways. All right. Adverse reactions common are sedation, dry mouth, constipation, weight gain. Now, our more serious are going to be cardiac arrhythmias because it does require ECG monitoring, overdose toxicity, and suicidal ideation. There is a high side effect burden here. So this is not a drug that you want to go to, a drug class that you want to go to lightly. All right. So finally, we have our last drug here that we want to talk about for non-approved ADHD use. That's going to be the modafinil. So this is off-label for ADHD in adults only. Promotes wakefulness and attention, possibly via dopamine and norepinephrine modulation. We don't really understand. The exact mechanism is unclear for this particular drug. Common side effects are going to be headache, nausea, and insomnia. Rare are Stevens-Johnson syndrome, psychiatric symptoms, or cardiovascular effects. So the quick note for this one is it's experimental for ADHD. It's used in treatment-resistant cases and limited evidence compared to approved options. So I do not believe you will get asked this on your exam, but just so that you've heard it, here it is. So why are all of these medications third line? These medications have weaker evidence and higher risks, reserved for refractory cases or when comorbidities like depression are dominant. So for the exam, no, they're off-label and rarely first choices. So some of the key considerations across all medications, first and foremost, is going to be age-specific dosing. Start low and titrate slowly, especially in children. Preschoolers 3 to 5 require specialist oversight due to limited data and growth concerns. Adults may need higher doses due to metabolism, but you do need to monitor for cardiovascular risks. Mechanisms: stimulants enhance dopamine norepinephrine acutely. Non-stimulants like atomoxetine and those alpha-2 agonists, they modulate norepinephrine more gradually with less striatal impact. Third-line agents have broader, less specific effects. Key considerations for side effect management. So we do need to address the insomnia with earlier dosing or sleep hygiene. We want to manage appetite loss with high-calorie snacks. We monitor vitals for cardiovascular risks, educate patients on abuse potential for stimulants, and withdrawal risks on the alpha-2 agonists. Then we have adverse reaction monitoring, so we screen for cardiac history stimulants, liver function for atomoxetine, and suicidality in all cases. Regular follow-up is crucial, especially in their first 3 months. And then final key consideration is going to be patient education for medications. Explain the mechanisms. Let them know, hey, stimulants are going to boost your brain's focus chemicals, and set realistic expectations. Let them know non-stimulants are going to take weeks before you see any change. And then we discuss lifestyle factors like the diet and sleep to optimize treatment. So for the exam, we focus on stimulants as first line. That's going to be your methylphenidate and amphetamines, 6+ years of age, in some cases 3+. Atomoxetine and alpha-2 agonist as second line, ages 6 to 17 with some adults, and off-label options as third line. So you got to know the age approvals, the common side effects like insomnia and appetite loss, and the rare risks like cardiac events and suicidality. All right, so stimulants like methylphenidate and amphetamines, again, this will be the third time you've heard it, so it should be solidified in your mind. These are first line for ADHD due to high efficacy. Approved 3 to 6 and up. Non-stimulants like atomoxetine, guanfacine, and clonidine are second line, ideal for comorbidities or stimulant intolerance starting at age 6. Third line options like bupropion are off-label and rare. Know their mechanisms. Dopamine, norepinephrine for stimulants, norepinephrine for non-stimulants, and motor side effects like insomnia or cardiovascular risks. For the exam, practice choosing medications based on age, symptoms, and contraindications. All right, that is the pharmacological section of the podcast, and hopefully that helps solidify some of the options that you have. Before we move on, though, we do need to talk about managing tics in patients with stimulants, because stimulants like methylphenidate and amphetamines, because they're the first-line treatment for ADHD, due to the efficacy in boosting that dopamine and norepinephrine to improve attention and impulse control, there is also a known side effect that could potentially, really disrupt the patient's life. because these medications are a potential trigger to exasperate tics. These are sudden, repetitive movements or vocalizations, things like eye blinking, head jerking, or throat clearing. Now, for PMHNPs, understanding how to handle tics in a patient on stimulants is vital for both clinical decision-making and certification exam scenarios. So let's walk through this systematically. When a patient on a stimulant develops tics, the PMHNP's first step is a thorough assessment to understand the tic's nature, the timing, and potential causes. This is going to ensure accurate diagnosis and guide management. So first, we need to characterize the tic. Ask the patient or, potentially their parent or teacher or guardian to describe the tic. Are they motor? Things like facial grimacing, shoulder shrugging. Are they vocal? Things like grunting or sniffing. How frequent and severe are they? Do they impair functioning or cause distress? Next, we can use a standardized tool like the Yale Global Tic Severity Scale. And this is going to quantify tic severity and impairment. So this is exam relevant here, y'all, as it's the gold standard for tic assessment. That's the Yale Global Tic Severity Scale. An example here, a child with new onset eye blinking 10 times per hour during class may report social embarrassment, indicating functional impact. We need to establish a timeline, so determine when tics started relative to stimulant initiation or dose changes. So tics often emerge within weeks of starting or increasing a stimulant, but may also appear later. Ask about tic history. Did the patient have tics before starting the stimulant, or is this new? Pre-existing tics, in situations like Tourette's syndrome, they may be exacerbated when on the medication, while new onset tics may suggest stimulant-related effects. Rule out other causes of tics, such as Tourette's syndrome, chronic tic disorders, or transient tic disorders. These are tics that last less than a year. Tourette's requires both motor and vocal tics for over a year, and they have to start before the age of 18. We consider neurological conditions like Huntington's disease or post-viral encephalitis, or medications like antipsychotics causing tardive dyskinesia. These are rare, but they are exam relevant for preparation. So assess for stressors, as anxiety or psychosocial factors can also worsen tics. Check for a personal or family history of tic disorders, ADHD or obsessive compulsive disorder, OCD, because these are highly genetic linked. Up to 20% of ADHD patients have co-occurring tics. We want to screen for comorbidities like anxiety or OCD, which can mimic tics or exacerbate them. Note the stimulant type. So is it a methylphenidate versus amphetamine-based? The dose and the formulation. Is it short versus long-acting? And then higher doses may increase tic risks. An example here, a patient on high-dose Adderall XR at 30 milligrams may develop tics sooner than one on lower doses of Ritalin at 5 milligrams. So tics may be stimulant-induced, pre-existing, or unrelated. That's why this matters. And you, the PMHNP, must differentiate all of these situations to avoid unnecessary medication changes. So for the exam, expect questions testing your ability to assess tic onset and rule out Tourette's or other causes. Now, once the tics are confirmed, the PMHNP must balance ADHD symptom control with tic management. Stimulants don't cause tic disorders, but can unmask or worsen them in susceptible patients. So here's the step-by-step approach based on clinical guidelines, the AACAP and also the APA. Step 1, reevaluate stimulant use. If tics are mild and ADHD is well controlled, try lowering the stimulant dose. Lower doses may reduce tic severity while maintaining efficacy. So an example would be reduce Concerta from 54 milligrams to 36 milligrams and reassess in 1 to 2 weeks. Switch to stimulant class. If dose reduction fails, switch from one stimulant class to another, methylphenidate to amphetamine or vice versa. Some patients tolerate one class better. For instance, a patient with tics on Adderall may tolerate it on Ritalin. And then finally here we have discontinue the stimulant if the tics are severe, functionally impairing, or persistent despite dose reduction or switching. Stop the stimulant. We want to monitor tics for 2 to 4 weeks as they may resolve off the medication. So this is a common exam scenario. I'm going to repeat that. Everything that we just discussed as far as the management is true, but for the exam, you're probably going to choose discontinue the stimulant unless another answer makes more sense. But that's going to be the safety profile that we're looking at. And remember, safety rules on the exam. So you would discontinue the stimulant and put the patient on a non-stimulant drug like guanfacine. All right, step 2, which is what I just said, we want to consider non-stimulant alternatives. So if the stimulants are discontinued, but the tic persists, we transition to a non-stimulant ADHD medication, less likely to cause worsening tics. Atomoxetine, Strattera. We've got guanfacine ER, or extended release, Intuitive. You've got clonidine, extended release. So for the exam, know that guanfacine and clonidine are first choice for ADHD with tics due to their dual benefit. All right, step 3, treat tics directly if needed. So if tics remain severe or impairing after stimulant adjustment, add tic-specific treatments. First is going to be behavioral therapy in children, comprehensive behavioral intervention for tics. It's also known as CBIT or CBIT. First line, teaching patients to recognize tic urges and use competing responses. So slow down the blinking of the eye tic. It's effective in 50 to 60% of the cases for patients, so it's a great place to start. It's non-pharmacological and exam relevant. Remember, on the exam, we're going to want to choose a non-pharmacological treatment first before we go to medications for our child population. All right. Medications for tics, alpha-2 agonists, so guanfacine or clonidine, like we talked about above, because these can treat both ADHD and tics. Antipsychotics can also be utilized here. So for severe tics, we have off-label use of risperidone and aripiprazole, so these may be considered as well. These reduce tics by blocking dopamine D2 receptors, but carry risks like weight gain, sedation, and EPS. So they're rarely needed, so specialist consideration is often advised. All right, step 4 is going to be monitor and reassess. So follow up in 1 to 2 weeks to assess tic severity. Remember, we're going to use that Yale tic scale. ADHD symptoms and medication tolerability also need to be reassessed, and then we adjust dosages or medications based on the response. So we want to educate the patient and their family members that tics may wax and wane naturally or come and go, independent of stimulants, and stress can cause the tics to become worse. And then we need to monitor growth, vitals, and psychiatric symptoms, especially if using non-stimulants or antipsychotics. So this process prioritizes ADHD control while minimizing tic burden and using a stepwise strategy to avoid over or under treatment. So for the exam, know the sequence: dose reduction, stimulant switch, non-stimulant trial, and tic-specific therapy. But if you get a question that talks about a tic problem that started after treatment and is impacting the patient's life, then the answer is probably going to be the safest answer, and that's going to be to stop the stimulant and switch to a non-stimulant. Okay, so let's go ahead and kind of finish up this discussion with appropriate psychotherapy for ADHD. For attention deficit hyperactivity disorder, there are evidence-based approaches, starting with those backed by the strongest research and are really associated with key theories, detailed descriptions, and practical examples of treatment modalities and exercises within the psychotherapy range. So psychotherapy is critical in the treatment of ADHD and the management, often used alongside medication in order to address the core symptoms like inattention, hyperactivity, and impulsivity, as well as associated challenges like emotional dysregulation and low self-esteem. So you'll need to recommend or coordinate psychotherapeutic interventions, or you can do it yourself, right, depending on your practice, in the real world as well as on the certification exam. So you will expect questions on evidence-based therapies and their applications. So let's go ahead and cover those. First is going to be behavioral therapy, and this includes parent training. So the strongest evidence, especially for children and adolescents with ADHD, this is supported by randomized controlled trials and meta-analyses from the American Academy of Pediatrics. It's most effective for ages 4 to 12, but adaptable for adolescents. Okay, so associated theory here, this is the operant conditioning from B.F. Skinner, forms the backbone, positioning behavior in shaped. It really shapes the consequences or reinforcement and punishment. So ADHD children struggle with self-regulation. So behavioral therapy uses structured rewards and consequences to reinforce desired behaviors and reduce impulsivity. Social learning theory, this is Albert Bandura, I believe, also applies because children learn by observing and modeling parent-teacher behaviors. So behavioral therapy modifies the environment to promote adaptive behaviors and reduce ADHD symptoms. So for children, this is really going to involve parent training to teach caregivers how to reinforce positive behaviors and manage challenging ones. Teachers may also be involved to ensure consistency across the settings. A lot of times teachers will get this training in their, parent-teacher conference weeks or, in times where they can come together as teachers and learn these skills in general. The focus is on practical, observable changes rather than insight or emotions, and that's going to make it ideal for ADHD neurodevelopmental nature. Now, treatment training programs, things like a parent-child interaction therapy or PCIT, or Incredible Years is another one. Here, parents learn to use positive reinforcement like praise or tokens for desired behaviors, things like completing their homework, and planned ignoring for minor misbehaviors like interrupting. So an example here would be a parent might say, "Great job staying seated for 10 minutes," and give a sticker towards a reward. Or maybe it's extra screen time or whatever is decided. For tantrums, though, they ignore attention-seeking behavior but redirect to a calm activity. Timeout, okay? So a timeout is taught as a consequence for severe behaviors like aggression. So parents practice a consistent, brief timeout, 1 minute per year of age, in a neutral space. Behavior classroom interventions, so teachers are going to use something called the daily report cards or DRCs, where specific goals like raise his hand before speaking are tracked, and students earn rewards like class privileges for meeting those specific goals. So an example here, a child earns a star for each class period they complete tasks without blurting out, and that leads to weekly rewards like choosing the classroom game. There's also a token economy, so children earn tokens, things like stickers or points, for behaviors like staying on task, staying in their seat, which can be exchanged for rewards like a toy or a specific outing. An example here would be a child earning a point for every 15 minutes of focused homework time, aiming for 10 points to earn a movie night. All right, skill building for adolescents. So teens learn self-monitoring, for example, tracking their own focus time, and goal setting, like breaking tasks into chunks. An example here would be a teen uses a planner to schedule study sessions, checking off completed tasks, and rewarding themselves with a break after 25 minutes. So why does this work? Behavior therapy leverages external structure to compensate for ADHD-related executive dysfunction. This is going to teach skills that become internalized over time. Parent training empowers caregivers, improving family dynamics. So for the exam, know its first line for young children and a key adjunct for all ages. The next therapy we're going to talk about is cognitive behavioral therapy, or CBT, for ADHD. Again, strong evidence for adolescents and adults with ADHD, supported by RCTs, which are those randomized controlled trials, and meta-analyses. It's less effective for young children due to the limited cognitive maturity, but highly effective for ages 13 and older. So cognitive theory, this is Aaron Beck. It hypothesizes that thoughts, feelings, and behaviors are interconnected, and maladaptive thoughts, things like "I'm a failure," are drive dysfunction. So in ADHD, CBT targets executive dysfunction and negative self-beliefs caused by chronic underachievement, combining cognitive restructuring with behavioral strategies. So we have the self-regulation model, this is from Barkley, also applies, and that's going to emphasize that ADHD impairs self-control, which CBT addresses through skills building. So CBT for ADHD is structured, it's goal-oriented, and tailored to address inattention, impulsivity, and emotional challenges. It's going to teach practical skills like organization, time management, and problem solving, while addressing negative thought patterns like, I'm never going to finish this. So sessions are typically weekly, delivered individually or in groups, and include homework to practice skills. For adults, CBD also tackles comorbidities like anxiety or depression, which are often found and are common in ADHD with adults. So first up, we're going to look at organizational skills training, so patients learn to use tools like planners or apps or calendars to manage their tasks. For example, an adult creates a daily to-do list, prioritizing 3 tasks and breaking them into smaller steps, like, write a report becomes do the outline, then write the draft, then revise, instead of just write a report. Time management techniques are going to include, 25-minute work blocks with 5-minute breaks to help sustain focus. For example, a teen studies for 25 minutes, then takes a 5-minute stretch break. This is what I teach my students in the PMHNP review courses, repeating 4 cycles before taking a longer reward, like playing a game. There's cognitive restructuring, so patients identify and challenge negative thoughts. For example, I'm too stupid to focus, and they replace them with a balanced thought. For example, I can focus with the right tools. So an example here would be a patient who keeps a thought diary noting a situation. For example, missing a deadline. The thought, I'm a failure, and evidence for against it, then reframes it. I'm not a failure, I just missed one deadline, but I've met others. Then we have distraction management. So patients practice environmental control. For example, would be studying in a quiet place or turning off phone notifications. An example here, an adult sets up, a distraction-free workspace using noise cancellation headphones and a do not disturb sign during work hours. Then we do need to talk about group CBT. So this is a structured program, CBT for adult ADHD, for example, that combines psychoeducation, skill building, and peer support. An example here would be a group session teaches participants to use a problem-solving worksheet to address challenges like planning a project by listing steps and potential obstacles. So why does this work? Well, CBT compensates for ADHD's executive deficits because it teaches practical skills and it teaches them to reframe self-defeating thoughts, and that's going to improve self-efficacy. It's especially effective for adolescents and adults who can engage cognitively, right? So on the exam, know that CBT is first line for adult ADHD psychotherapy and adjunct for teens. All right. Third is going to be social skills training. So there is moderate evidence here, particularly for children and adolescents with ADHD who struggle socially with things like interrupting or missing social cues. There is support from randomized controlled trials, but it is less robust than the behavioral therapy or CBT. Usually social skills are effective for children aged 6 to 18. So our theory here is going to be the social learning theory, and it emphasizes learning through observation, through modeling, and through reinforcement. ADHD, it impairs social reciprocity because of the impulsivity and inattention. So social skills training provides explicit instructions on how to practice and build competence in social environments. Then there's the developmental theory. It also does apply here because social deficits in ADHD may lag behind peers, and that's going to require targeted interventions for development. So social skills training is going to teach children and adolescents how to navigate social interactions, like making friends, taking turns, or reading nonverbal cues from others. It's typically delivered in group settings to allow real-time practice and feedback so they can play, right, and they can mimic, often with therapists modeling the behavior. Now, parents and teachers reinforce skills outside the group sessions. For adolescents, the focus may shift to peer relationships and conflict resolution. Now, while less effective as a standalone treatment, it is valuable adjunctive for addressing ADHD-related social impairments. So some of the things that we can utilize are going to be role-playing. This is where children practice scenarios like starting a conversation or apologizing for interrupting. We can use social scripts where patients learn structured phrases for social situations, like a greeting or responding to criticism. So a good example here would be a child practices saying, "Thanks for inviting me," to build gratitude and connection, and then he's going to be able to go and rehearse it with peers while he does role play. There's also video modeling, so children watch videos of appropriate social behaviors and then they imitate them. We have friendship skills groups, so these are structured groups that teach skills like cooperation, empathy, and conflict resolution through games and discussions. So an example of that would be a group plays a cooperative board game while a therapist is prompting turn-taking and praising the teamwork. So great job, waiting your turn, and things like that. Then we have the parent-teacher reinforcement, so caregivers reinforce skills at home and at school, and they're going to use those praise and rewards for applying learned behaviors. So a parent rewards a child with a sticker for using a learned phrase like, "Can we share?" during play dates. So why does this work? Well, social skills training addresses ADHD-related social deficits by providing explicit instructions and practice overall, and that's going to help leverage peer feedback and peer reinforcement. It's most effective when combined with behavioral therapy. So for the exam, no, it's an adjunctive therapy for children, adolescent with social challenges. And again, that was social skills training. Mindfulness-based interventions is also an important one to review. So this is emerging, but it does show promising data and evidence, particularly in adolescents and adults with ADHD. So mindfulness-based interventions is supported by smaller RCTs and meta-analyses. It's less robust than CBT, but growing, especially in ages 13 plus. So here is the mindfulness theory. So this emphasizes present moment awareness and non-judgmental acceptance. And this is countering ADHD, impulsivity, and distractibility. So the neuroplasticity model suggests mindfulness strengthens prefrontal cortex functioning, enhancing attention and emotional regulation. In ADHD, mindfulness targets deficits in self-awareness and impulse control. So mindfulness-based interventions such as the mindfulness-based cognitive therapy, or MBCT, or mindfulness-based stress reduction, MBSR, this is going to teach patients to focus attention, regulate emotions, and reduce impulsivity through meditative practices. Now, sessions are typically group-based, they're weekly, and include guided exercises and home practice. For ADHD, mindfulness is adapted to be shorter and more structured in order to accommodate attention challenges. It's particularly useful for patients with co-occurring anxiety or emotional dysregulation. Some of the modalities and exercises that they'll use in mindfulness-based interventions are going to include body scan meditation. So an example of that would be a patient lying down, guided to notice sensations in each part of the body. For example, feel your toes, then your feet, and we walk them through this body scan. And we're going to practice this for about 5 to 10 minutes daily to build focus. Breath awareness, this is where a patient would be counting their breaths 1 to 10, then restart for 3 minutes, redirecting attention when distracted, and we can often use apps like Headspace for guidance on this. There's mindful listening. This is where patients practice fully attending to sounds and conversations, countering inattention. So this would be when like a teen listens to a partner's story without interrupting, then reflects on what they heard from the partner in order to practice in group sessions. We also have the STOP, S-T-O-P technique, and this is where patients learn to stop, take a breath, observe, then proceed to manage impulsivity. An example would be before blurting out in class, take a pause, breathe, and decide whether to speak, practicing this in role-playing. Then we have mindfulness apps, tools like Calm or Insight Timer to provide guided exercises tailored for ADHD with short sessions. These usually last between 5 to 10 minutes. So why does mindfulness work? Well, it enhances self-regulation and attention by strengthening prefrontal networks, offering a non-behavioral approach for patients resistant to CBT. It's best as adjunct for adolescents and adults. And now for the exam, no, it's emerging but not first line due to limited large-scale evidence. I also want to make sure that we talk about family therapy because there is strong evidence to support children, adolescent with ADHD and family conflict coming together for a systems theory approach. And remember that systems theory is Murray Bowen, and this views the family as an interconnected unit where dysfunction in one member, like the child with ADHD, affects the whole system or the whole family. So ADHD-related behaviors can strain family dynamics, and family therapy addresses these patterns to improve communication and support. We also have attachment theory under the family therapy area. This may also apply because as secure patient-child bonds facilitate this supportive and healthy ADHD management. So family therapy focuses on improving family interactions, reducing conflict, and supporting the ADHD patient's treatment plan. This is really going to involve parents, siblings, and sometimes there may be extended family. And that's going to address how ADHD impacts relationships, things like parental stress and sibling resentment. Sessions are typically weekly, led by the therapist, and combine psychoeducation with communication skills. It's most useful when family dysfunction exacerbates ADHD symptoms or it hinders the treatment adherence. That's when we would use family at its best. All right. So that's going to include psychoeducation. That's going to include communication skills training, problem-solving exercises, and family meetings. Family therapy is going to reduce stress and improve adherence to ADHD treatments by aligning family dynamics. It's adjunctive, not a standalone treatment. So for the exam, know that family therapy is useful when family conflict is prominent. All right, so I know that was a lot of information in that section. We're just going to do a quick summary. So behavioral therapy with parent training, most evidence-based, rooted in operant conditioning, and first line for children ages 4 to 12. Exercises include token economies and daily report cards. CBT is highly effective for adolescents and adults, 3+, based on cognitive and self-regulation theories with tools like planners and cognitive restructuring. Social skills training helps children and adolescents aged 6 to 18 with social deficits, and we're going to be using social learning theory and role-playing. Mindfulness is emerging for adolescents and adults, 13+ of age, leveraging mindfulness theory with exercises like breath awareness. And then we have family therapy, which supports children and adolescents aged 6 to 18 when family dysfunction is present, grounded in systems theory. For the exam, you're going to prioritize behavioral therapy for kids and CBT for adults. Know the theoretical basis, operant conditioning, cognitive theory, and be ready to recommend specific exercises. Remember things like token economy. And then combine therapies with medication for best outcomes and tailor to age and comorbidities. All right, that's psychotherapy in a nutshell for ADHD. A lot of stuff here, right? A lot of key education points, a lot of key medication points that we have to consider. I would highly recommend that you create an outline for your patient, a handout, a paper handout, or an email that you can send to the patient and the parent that's going to talk about, the ADHD treatments, the different type of therapy, what exactly is ADHD. As a matter of fact, if you're a student in our program, there is a handout for you that you can download in the appendices section of the student portal that you can utilize as a patient and parent ADHD handout. So just an extra little tool that you can utilize. And that's really it for ADHD. I know it's a lot. There's a whole lot more we could actually talk about. I mean, ADHD for a lot of people is a very specific treatment area that they focus on for the entirety of their career. So as PMHNPs, you will do some medication management, you will do some psychotherapy, you will work with families in this area. And as you become more proficient, you'll see how valuable you are as a PMHNP to the family and to the patient in helping them in a holistic approach, mind, body, soul, spirit, Eastern, Western medicines, all kind of combined together, which is why, in my opinion, NPs are so great at this job because we take into account all of those areas. That's it for today in the ADHD podcast. Remember, I'm Dr. John Rossi for Clarity Education Systems and PMHNPtesting.com. That is where we have both on-demand and live sessions available for students that are preparing for their PMHNP certification exams through the ANCC and AANP. It's also for those currently practicing LCSWs, PMHNPs, MDs. If you're in the mental health world and you deal with these topics like ADHD, this is a place where you can come and find out lots of information and apply it to clinical practice. If you are a PMHNP or a nurse and you're not studying for your exam or don't need to, you can still take the courses in order to earn a lot of continuing education that can go towards your annual requirements for both your nursing license as well as your nurse practitioner license. All right, please let me know if you have any questions. You can drop them down in the comments or you can contact us directly through the websites. Thank you for listening today. Remember, there are some practice questions down below in the description section, so make sure to study. Practice questions are key to passing the exam. Y'all have got this. I have no doubt that you're going to do great on the exam, and then even more importantly, you're going to go out and do amazing things as nurse practitioners. As I've said before, we are the future of healthcare. United States healthcare does not move forward without us. So go out there, be mentors, be legislators, be the best providers that you can possibly be, and you can do that by continuing your education daily and working in collaboration with other interdisciplinary team members. Thanks for listening. Have a great day, night, wherever you're at right now listening to this. I will be with you again next